What about patients who smoke? So certainly smoking is associated with higher failure rate than patients who are not smokers, and that goes all the way back to the early 90s. Not only are there increased failures, but there are increased complications, biologic complications, whether that is bone grafting failure, implant failure, or soft tissue healing problems. Certainly a lot of complications. Low primary stability and smoking is associated with early failure, and this is a pretty recent study that looked at that. And so if we're having lower primary stability and early failure, then these are going to be patients that you probably don't want to think about early loading or immediate loading, or maybe not even immediate placement. And increased failure in smokers, maxillary bone loss, and periimplantitis. So we know that smokers are compromised patients, and so having this type of objective measurement would be extremely helpful in patients that smoke. And then, of course, looking at increased crustal bone loss in smokers, and especially in patients that have posterior implants and when those implants are more narrow diameter. And then, of course, the late failures and mucosal problems are also issues in smokers. And so not only do we have to talk to them about failure of their implants, but also periimplantitis and other mucosal complications or healing problems. And so this is a patient exactly like that, a 68-year-old male who's a longtime smoker. He has severe localized periodontal disease and overall periodontal disease as well, and he is missing a tooth here. You can see that there is some bone loss in the area where the tooth was extracted, but certainly adequate amount to be able to place an implant. And so when we go in, we can see that after the extraction, he healed, but not a perfect healing. And, we know that even extraction socket healing is compromised in patients who smoke. And so we know that up front, and we tell the patient up front. And so he has to really understand that having immediate loading or even having had an immediate implant is really not an option for him in this case. So you can see at the time of placement, we have a value of 62 on the ISQ reading, and which is okay, and certainly gives us some confidence that the implant is stable, but certainly would make me think twice, definitely not considering immediate loading, and also thinking about what type of placement protocol. And so with the 62 and a defect around the implant, then we elected here, of course, to do some grafting around the implant and bury the implant as a two-stage placement protocol. And so you can see here grafting around the implant and with a membrane, some guided bone regeneration, and primary closure. So this patient is going to heal for several months and then come back, and we will uncover the implant and then do traditional loading.